All right, so let's talk about training. The way we framed this was, because of the way that it's often presented in the literature, is whether there was or wasn't a certain threshold of training. So the question before you is 40 or more hours of training focused on the development of core competencies and or specialized condition-specific curriculum. What is the likelihood that that component is related to improved patient outcomes through community health workers? Discussion about this? Claudia, yes?
Well, I'd suggest it may be worth your discussing a bit.
Oh, yeah, sorry. Maybe they can mic me up, too.
I think it may be worth your discussing a bit why you decided to frame the question the way it is here, and the thought process is, since we are changing the process significantly for people who have been on the committee, from looking at effectiveness and looking at whether the studies had enough data to prove effectiveness, as opposed to looking at the data as to whether it contributes to improved health outcomes, and how we take the studies in order to phrase our answers to this question.
So I don't want to lead the council through a long revisit of this, but it was a conversation we had with the CPAC advisory board and many members of the council. We were just grappling with the idea that for this topic, this type of topic in many ways, that a vote of whether the evidence was adequate on a particular component would not be viewed as helpful to decision making. There was a broad recognition that the literature on this kind of intervention is not as strong as a specific test or treatment might be, and that's still something that you may want to factor into your thinking about how likely you think it is or isn't. But there was a feeling that even with a relatively limited database, that there would be value from gaining CPAC's impression of whether it was or wasn't more or less likely. That didn't come out well. Whether it was more or less likely to be an important component of CHW effectiveness. Bill?
I think it's a spectacular improvement in what we're being asked, because the way I'm reading this and hearing it is that we're now not simply asked to evaluate the evidence, narrowly construed as it came across in studies, but we're actually asked to contextualize that, essentially make a sort of Bayesian, based on everything you know and now factoring in those data. What's your overall assessment of the likelihood of the answer to this? And I think it's much more salient than narrowly focusing on, especially in a question like this, something just about the narrowly construed evidence.
Well, don't get too comfortable with it, because we'll probably go back to the old version. But some quality improvement is possible. Yeah, I think it was also recognizing that, again, community health worker programs are in many ways all unique. They all involve a different mix of components and a different context, both patient, system, and community. So it was going to be impossible to say, is the evidence adequate to say that community health worker programs work? So focusing on the components and trying to get the context, as you said, is what we thought we'd shoot for. Josh?
I absolutely agree with what Bill said, that this does contextualize the issue in a different way. On the other hand, having spent all of 2.5 hours becoming familiar with community health workers in general, I'm not sure that I have adequate context without some amount of evidence. And just a clarifying question, I don't recall that this particular variable, if we can call it that, was actually examined in any of the studies that we reviewed.
I'm going to try and find the page. It was, and it's probably even on one of the slides. Maybe I should look at this. Dan, isn't it on one of the slides? The training.
Yellow
Which I'm trying to find the evidence, because this is helpful. We'll find the evidence on training is
slide
on
33.
slide 33.
The one with all the yellow highlights.
Yeah.
They map these one to one.
bring everything up here. Give a-
Oh, yeah.
Right, so I'm looking now, slide 33. Slide 33? Nope. What slide number, sorry?
My number's 33. 33.
That's slide 33 in the deck, but it's also on the cheat sheet, Steve.
Just for the cheat sheet.
No, not 33, for me.
I think there's a
All right.
The second page is the cheat sheet.
second page of the cheat sheet.
All right.
Blue tab has the cheat sheet.
All right.
I never use cheat sheets.
Training of CHWs, okay. So the best source to refer back to for right now, under the blue tab in your binders, those succinct summaries, I've heard my staff call them cheat sheets, I don't know why. We call them succinct summaries. On the second page, under the heading is Key Components of Community Health Worker Programs, Brief Evidence Summary. On the back, you'll see Training of CHWs. It'll give you, again, a very high-level summary, the 18 of 27 studies, et cetera, et cetera. And it was in one of the slides, too. I just apologize I couldn't find it quickly.
Yep, and it was in the text of the preliminary report as well.
Right. Okay. Why don't we move ahead then, if there are no further comments? We're going to unveil the voting mechanism again, and I'll hand it over to SJ to lead you through that. Sorry, Cy, quickly, yes?
Just very briefly.
Sure.
So, this is about contribute to improved health outcomes, and are we still going to limit this to clinical and utilization?
Yes. However, the final report will clearly reflect the comments about the relevance of outcomes beyond the traditional health outcomes and utilization measures that are the subject of most studies. All right. Now Bill wants to say something else.
I'm just saying, but you're not asking us to construe health as narrowly as they've been measured in the studies necessarily.
Well, I guess my guidance was to do so because that's in terms of the literature that we have, that we do have, and that we've presented today, it has emphasized that. You can intuit other outcomes, I suppose, but my preference would be for the vote to consider this to be within, the definition that we started with. Ellen?
And we're thinking about these from the perspective of a Medicaid program?
Yes, I'm sorry, that's right. Our votes have, traditionally, we've recognized that there are lots of different perspectives on what value different interventions bring, both the clinical value and the cost effectiveness or kind of budget value. We have asked the council so that they can have one perspective and that it's a little bit more clear from whence their votes are coming, to try to assume the perspective of a state Medicaid program. So in this case, I have to blur that a little bit because we are assuming primarily that that community health workers are working with with delivery organizations, that they're part of ACOs or patient-centered medical homes. But from the value perspective, when we get there, we're going to be, again, asking you to consider it from the perspective of the entity that has to pay for them, whether that is a payer or a provider organization.
So this is a Medicaid organization that has people in the program based on income, they're state residents, and it is part of, that funding comes out of the general fund.
Well,
with
let's turn to
everything
the funding when we get to the value
I
piece.
know, I pushed it too far.
We'll get there, and we'll have to make sure that everybody's clear on that. So let's
Okay.
hold that for 1 sec as we turn to the votes on the clinical outcomes, which will include impact on utilization, because that's viewed, most of the utilization findings are reduced ER use and things like that are viewed as being good for patients as well as other people. Yes?
So,
Tony.
by some definitions, when you talk about patient outcomes, cost is one of those measures. So when we talk about health outcomes, are we excluding cost as one of those measures?
Yes,
Okay.
it will come back, but not now.
Okay.
All right, time to get your feet wet. SJ, why don't you lead them through the vote?
So for returning CPAC members, this is the same technology we've used, so it might be familiar. Just select, once I put the time on the clock, you'll see it on the screen. Just select the number of your corresponding vote. You can change your mind, click as many times. We'll just register the last number you press before the time is out. I can restart the time if you need to, but so don't worry. And any questions? Is that clear? Good. You're now. So time, I will start now.
Okay.
Anyone intentionally abstain from voting? With the
No.
exception of Rob Zabowski. Okay.
Are we good?
Now we only have 13. Okay, we'll do that one more time. I think one just didn't register.
We have to look for the little green light, is that right, to make sure it's
That will
registered?
show you that it's registered, so if you don't see a green light, it might not be picking it up.
These are highly educated people at the table, I assure you.
There was no test question.
No, it's right, it's right after the test question. Okay.
We're going to have a retreat, a day-long retreat.
Let's try it again. Time and slides. You have 14.
All right.
Okay.
Thank you. All right, on to the next topic. Okay, so in-person home visits. Now, I will acknowledge first, before I'm sure this may be somebody's question, again, we know we are dealing with apples and oranges, lots of different types of programs, so it might be that for a particular target for a CHW program, in-person home visits might not be viewed as being as essential as for others. We thought it would still be helpful trying to generalize to the variety of community health worker programs you've heard about, whether you think in-person home visits are, again, more or less likely to be important for improved patient outcomes. And again, I'm pretty sure that we would have this on our brief summary, which I'm looking for again. Yep, the same page, number 2, a brief summary, and I'm sure it's on one of the slides as well. Now, questions? Mitchell, did you have something? Yes.
Clarification.
Sure.
So I'm focusing on the word includes. We're not saying only in-person visits.
That's
That
correct.
The connection includes at least one.
That's correct.
Any other questions?
Other questions or points of, okay? Looks like we're ready to vote on this one then. All right, SJ,
Ready? Go.
10 seconds. We still need some theme music, I know we do.
It's like we have 14.
Can the audience all see these? Good. I just want to make sure that they can. So for in-person, we have 65% likely and 37% highly likely. Okay. The next voting topic is the length of visit. This was something, again, that was obtainable from the literature. Again, we're not asking you to say necessarily that this is or isn't. Well, in a way, we are asking you to rate how important it is to the outcomes. Questions about this one? You guys are as eager to get to the round table as we are. Sounds good. All right, let's take the vote.
All right, ready? Go.
Okay. I think people can see the results there without my repeating them. All right. Okay. Now, patient participation incentives. I think it was a very valuable conversation that we have already had on this topic. The word incentives is not a good single term for the different ways that patients have either been, again, have received everything from gift cards to material objects to help with their home care or health care. So I'd be open to thoughts on how we want to consider this specific question, if we want to narrow the field on which to vote, or if we want to do something else. Mitchell, why don't you try to speak in the microphone just to make sure other people
sorry.
can. I'll
Instead of
hear you,
looking at
whatever you say.
I'm not being rude by putting my back to you. So I was going to say, I was going to abstain from this if we don't change the wording or the parameters, because I think incentives have two different classes of items are included here. One is things that promote the program, such as we discussed the vacuum or transportation to get to an appointment. The second one is incentives like the gift card or something to encourage the person to participate. So my suggestion would be, if we can tease out those two categories, I would feel more comfortable in commenting.
Rob?
Two comments. First of all, since this is intended to be a Medicaid populations have free transportation to visits for the most part. Second of all, did you look at these studies to see whether the incentive was used to participate in the program or to make sure that people participated in the evaluation of the program?
It was, Dan, you want to comment on that?
I think it was mostly the program, though.
I was going to see, one reason that we might not want to vote on this one is because I feel like we owe you a more detailed breakdown of this category. Because what I would like to know is, it's in the report, but how broken down is it?
The most common type of incentive reported was payment for completion of an evaluation or follow-up assessment.
Most common, okay.
Can you say that?
And I also, okay, yeah, I'll say it with the microphone when I just read it. So on the specific question that was just posed, okay, the most common type of incentive reported, and I'm sorry, I don't know that well, 11 studies out of how many? 17? The most common type of incentive reported was payment for completion of an evaluation or follow-up assessment. So that's far from gift cards and even some of these other things we've been talking about.
It is.
Well, it's also the completion of the evaluation may be for the completion of the evaluation of the grant that's supporting this,
Right.
which is not what the real world you're really looking for.
Right.
So I think this, A, would be misleading to the group, but also misleading to someone who's reading this in the future and making decisions off of this, not knowing exactly what those incentives were.
Yeah.
Sorry.
Let me just quickly say that I made a note to myself that we also had the earlier issue when you saw the table that we didn't break out. It said 100% of studies that it had a positive impact had patient incentives, and 0% didn't. But those were studies reporting. So we didn't really break it out whether they were reported and were absent and didn't have any kind of patient incentive, or whether they weren't reported. I just thought there was enough lumping in that table that we might all benefit from seeing it more broken down. But even again, revisiting this type of incentive, and later when we actually go over the draft best practice recommendations, one of them, which was generated from the community of policy experts, was that you don't need incentives, specific incentives, to get patients to do these in their experience. So my recommendation to you all would be not to vote on this particular question at this time.
Can I ask
Thoughts?
one more thing when you're
Yes.
looking through these and sorting? Can you also look at which ones you looked at outcomes down the road? Because when you look at, behavioral economics, if you pay people to do something, they're much more likely to do it. When you stop paying them, you may get a lower level than if you never paid them in the first place. So I'd like to see down the road if it actually is worse to give people cash.
My guess is that we won't have that kind of detail in the published literature, but it's something we may want to talk or hear from the policy roundtable later. Yes, Chris.
Steve, I'm quite passionate about this subject. I was just curious as to whether, if it were possible to break out this question and bifurcate it between incentives that drive healthy patient behavior and incentives that promote participation or completion of a study. That seems pretty clear.
I think it is one thing we've never done before, but I'll certainly consider whether we can as a group. We would need to do some further work on our side to send something to you. Whether we wanted to then ask you to vote on a more, like we could send you a one-pager specifically on this, trying to break it out. If we wanted to, then we could have a vote virtually through the internet after this meeting and include that as part of the report. It wouldn't benefit from the same kind of deliberation together or public transparency to the same extent, but it's something that I'm seeing some heads nodding, others not. How about we take it under advisement, but with the idea being that this may be something that would be valuable for decision makers to hear about if we can do a good job of providing the kind of evidence that would help. And again, we may want to bring this up with the policy roundtable and see if they have any guidance on this point. So,
And Steve, even if you do, in the further deliberation, find that there's not something to present to us to vote, that in itself would be good to include in the final report.
done. Okay, now,
And
yes.
not to belabor it, but
Sure.
it's also clear from what Rob pointed out and looking through this, that those incentives that were included that showed a benefit were in studies where the incentive was simply there to get people to do the evaluation. So, I mean, I actually be quite comfortable voting. I know where I'm going with this. If
That
that's
it's not at all
Yeah, that it's
likely.
not at all, but I think it's fine either way.
I had a suggestion that we take a vote on how many want to vote. Rob.
It's a filibuster.
Don't even. 12 hours, am I ready? Yes, all right. Pink tennis shoes, I'm all set. Rob, do you have something to say?
Yeah, speaking from the point of view of a Medicaid program, if there are enough studies here that had incentives used to get people to do things to further their health care, and they can be separated from the incentives to get them to fill out the form, that would be helpful, because I think knowing our department and how we go about thinking of things, the fact that we would be paying for incentives is going to flavor the response to this program. I've got
Understood.
2 colleagues, I think, out there. They can comment on that as well, but I think that that would weigh heavily on our thinking.
Okay. I think we're going to table it for now, and we're going to come back to you. It will probably come up in the roundtable. We can learn a bit today from the policy experts, again, from their perspective. But as far as taking a specific vote, let's hold off. All right. Can we go to the next one? Okay. This is matching the last one. Yes, it is. Okay. We're doing okay. Matching. We've talked a fair amount about the evidence, if you will, on matching. This is at the bottom of page 2 on your brief summary. In what's in the published literature, the types and amounts of matching. Questions about or comments on this before we vote? Okay. Looks like we're ready to vote. Everybody grab your...
All right, ready, go.
All right. 79% and 21%. Okay. Any comments about those votes as we move to vote on value? And again, these are targeted votes on value linked to the earlier conversation. All right, so here's the question. Does the budget impact analysis of the specific asthma CHW program described in Krieger suggest that a community health worker program with these outcomes and these costs represents a high, reasonable, or low value? And I'm about to be handed a very important piece of paper, which is a summary of these outcomes. I think it was Rob who asked a little bit more about what we really saw. Okay, Krieger. They measured the impact on urgent health services over the past 2 months and looked at the percent change. High-intensity receivers of CHWs had a 17% decrease. Low-intensity had a 4.6% decrease. The p-value is 0.02. So it's an absolute change from a decrease, I don't know what the these are percent changes. So I don't have an absolute, I have a relative change. 17% high intensity, low intensity 4.6%. Another outcome,
That's in the proportion using.
oh, I'm sorry, okay, so it's not in the proportion using any urgent health service in a 2-month period, there was a 17% decrease.
Correct.
But I wish I could say from what to what.
From 23% to 8%.
Okay.
That's
23%,
They used the baseline values from the previous, the baseline table, not from that table.
Oh, sorry.
So that's why the
Okay.
numbers are not quite the same.
Okay.
so do we have absolute change or just percent difference?
Yes, from 26% to 8%.
Okay. So in the baseline period, there was a 26% use of urgent health services, and it dropped to 8% in the high-intensity community health worker program. And the low-intensity, it went from
21% to 16%.
21% to 16%. This was a randomized trial.
Right.
Okay? The caregiver quality of life score, so the parents, oh, yes, sure.
Sorry, just to jump in.
Yeah.
So these were percentage point differences. When you said 17% and 4%,
Proportion.
it was really 17 percentage points. The percent difference would be much larger.
Yes.
So.
Yes.
Yes, that's why I
more
wanted to
than
get that
50%.
straight.
Okay, got it. Thanks.
These are absolute differences. The caregiver quality of life score, again, primarily parents, I would guess. Okay, and unfortunately, I don't know what the scale is here, but the change in score was 1.6 points for high intensity and 1.0 points for low intensity. It was statistically significant. And I apologize, I'm not sure we will know the scale of that.
1 to 7.
1 to 7.
Higher scores indicating better quality of life.
Okay, so on a scale of 1 to 7, with 7 being the highest quality of life, there was a change of 1.6 absolute points in high intensity CHW and 1.0 in low intensity. I got just a couple more in terms of days with activity limitation over the past 2 weeks. They looked at the change in the number of days during those 2-week periods, and there was a decrease of 4.1 days of days being limited among high intensity and 2.6 days in the low intensity arm. Things that were not significantly different between the two were the days using escape medication over their controller medication and days missed school and missed work by adults. So I apologize that we didn't have that in a nice written format for you all in one place. But those were the key clinical, quote-unquote, outcomes of the Krieger study. And then you probably remember the economic outcomes that are they in the, yes, the economic findings are on these brief summaries on the very next page from the one we were just looking. Okay. Who has a question? Alistair.
Yeah, on the economic, I know it came up earlier, I don't know if you
Yeah.
have any more information now about the, some scale to your cost estimate in terms of what proportion of the Medicaid program that we're supposed to have in mind this represents.
Oh, yeah.
Otherwise, it's kind of just numbers floating free of context to me.
It's a good point. I mean, actually, what's funny is that we've had total costs for treatment of Medicaid kids with ADHD before, and I know those kinds of numbers. Now, I'm afraid, unless one of the Medicaid folks on the CPAC, or even in the audience, I'd say, the question for context here is, if we're thinking about spending more, what percent on the base is this an increase? So what's the base spending, at least for these kids in general, such that we can view an increase of 125 million on the population basis within some context? It's a good question. I'm afraid we're not going to be able to help. Steve?
Just a question with respect to the salary of
Yeah,
the
can you use the,
worker.
sorry, can you try to use the?
Yeah, a question on the the salary of the worker, it seems like it's probably a variable for which a sensitivity analysis might have a significant impact. There was some testimony by somebody that had contributed some public comment, I don't remember the person's name, but suggested that the salary was a little closer to $25,000 to $30,000 per year on average. May we include that in the thought process for approaching this?
We actually did that analysis. Dan, do you remember what the salary threshold was for cost neutrality? We did that, as well as the caseload, we did a salary.
It's in the report.
All right, it actually is in the longer report. We'll find it for you in 1 sec. My memory was that it's around 17,000. It's a race, who can find it first?
Salaries decreased by 2/3.
Oh, shoot.
So 40,000.
Do the math.
Have an actual number.
Do the math. What's 2/3 of 40?
The one for the Massachusetts College.
In the preliminary
About
report,
26.
the
How much?
assumption
20?
is 40,000.
All right, so we actually did it at one point, I'm sorry, the actual number's in here, but at a salary of $26,000 per year, the Krieger study would have been cost neutral in year 1.
I think that increased by like 26.8. So the salary would be closer to 13 or 14.
Is that worth letting set in about,
Sorry, go ahead.
isn't that worth letting
Yes,
set
absolutely.
in that means that if people were, even if they're paid more than that, it still could be highly valuable if we think that the outcomes that you told us are worth that increase in cost?
That's true. I mean, the hard part is that we have to pick a salary on which to vote at this point, so I don't think it's really going to provide a very coherent way to vote if people are factoring in different potential salaries. I think we will certainly continue to note and perhaps highlight that the benchmark salary of $40,000, could be lessened and that there's a break-even point at 26. But I think at $40,000, we want to vote on that. But as Bill said, that still will ask you the question of whether the benefits gained are worth the cost of the program. So, yeah.
So 40 is what they were paid, that's actually from the study, and then you guys just used that and extrapolated it for our New England analysis.
40 was actually not what they paid them in Seattle. It was a number that was an average of a variety of different
Oh, okay.
programs.
Okay.
And we tried to use New England as the benchmark for that.
Great.
So we actually used New England data.
Okay.
And some are paid more and some are paid less. Rob?
Probably won't be invited back after this, but given a lot of the querulous faces I'm seeing here, it may be interesting to add a fourth possibility here that no conclusion may be drawn as a choice.
You're not invited back.
So Rob and I will start our own meeting. Because
There
I'm not going to be
are many
invited back
committees
either.
that do the we cannot decide thing, but we're going to try and push it towards some judgment. We do try to capture all the caveats, with all my unfortunate joking aside. I like it when you guys raise the problem that you feel like you're being asked to make a vote in a situation in which the evidence is difficult, the perspective is challenging. I still want to try and push through while noting all of that, but I do hear what you're saying. So now that's generated several other comments. So let me start with, actually, I think Rob, and then we'll come down to Austin.
Well, I just want to clarify, Steve, how I'm thinking about what we're voting on here. This is not a question about whether CHW programs work for asthma in general. It's a question of whether a program, a particular program, at one point in time that had certain characteristics and produced certain outcomes and costs had high, reasonable, or low value.
Right.
That's
If
it.
you could transplant this program into New England and get the same outcomes at the same cost that we've shown here, would you, and someone asked you, is this a good value, high value, is this a reasonable value, or is this a low value for our healthcare system?
It's
You
based
need
on,
the-
it's based on this particular program.
Correct.
And all those characteristics, and so
Yes.
folks are not worried about saying CPAC is voting against CHW programs for
No.
asthma, and
No.
that's okay, I want,
No.
so I think that that's an important thing for the panel to
Right.
keep in mind.
That's why it's already, whatever vote you take already exists in a kind of arm's length distance from reality, right? And we're acknowledging that. But we could have created a fictitious program and made up everything and asked you to vote on that. We chose to focus on a specific real-world program from which we have real data, and then you have to assume whether that would transplant here and all of the other issues that have been raised about the baseline and about the salaries. So now I know there's some other comments. Mitchell and maybe Keith.
So if you could state that to everyone who reads the report, I would be much more comfortable. I am very concerned about perceptions, and that if we do a vote based, and I agree with you, that's what we're being asked to do, but at this point, I'm planning on abstaining because I'm afraid that that's not how the results of the vote will be perceived by people looking at the report. And that's my concern.
I can assure you that we will keep the part about it being about the Krieger study in every section. And I'm not saying that that's... No. I understand.
So I think that brings, that context brings Austin's question of context to the forefront. And it's not so much what do we spend on Medicaid for treatment of these individuals in New Hampshire. What were they spending on Medicaid for treatment of those individuals in the state in which that study was done? So I have some idea of what's the relative added expense here.
Sorry, I'm trying to figure out how to get some better data. Let me just ask my staff over here. What I'd like to have is the cost per patient of the program. I know it's in there somewhere, the cost per patient of the cost offset. And the base.
We're answering a
and the
different question.
baseline.
Somebody asked about the baseline
Right.
cost to treat a patient with persistent asthma.
Right.
Just to give a sense.
But now we're dealing with hundreds of millions of dollars. I need the per patient numbers to make sense of that number, unless you want to multiply that by the total number of patients in New England.
Yeah.
Now we're going to go back to the table. I'm sorry, I had Keith next and then Bill.
Well, and I guess as we're figuring out those numbers, I'm reading through the public comments section, and Krieger responded to some of this and threw in some different numbers. I guess it was more updated, I presume, since '05. And I'm just wondering, are we taking any of that into consideration?
I'll let you comment on that. Yeah. It's a good question.
So, he did respond in a lot of detail. And so the first paragraph of his comment section is based on preliminary data unpublished from more recent research. So there wasn't time for us to try to incorporate that in as a sensitivity analysis. We certainly could do that moving forward if that's of interest. He referred us to a community guide from the CDC that had other economic evaluations of asthma programs. Not all of these were CHW based. Some of the studies were actually in our report. Other studies are also unpublished, and a fair number of these are also those pre-post evaluations that, based on our selection criteria, were excluded. There is a 2009 study that was not included because it didn't hit any of the search terms that we were using for our search. Again, we echoed the ARC approach, but in retrospect, it could have been included. One of the interesting things about this study, in contrast to the 2005 study, is that there were benefits seen in quality of life and I think a couple of other measures of symptom-free days, but no significant changes in resource utilization for urgent care. So, so a little bit different, not necessarily a source that we could have used to estimate a budgetary impact. Bill, do you have a question for me or Steve?
I have a comment.
Oh, okay.
Thanks.
In a crass attempt to influence everybody's vote, what I'm hearing from what you've told us, if this analysis is correct, is that at $26,000 a year, you would not only get all the health benefits that you reported to us, you would also be cost neutral.
That's correct.
So at a salary less than that, you would get all those health benefits and save money.
Mm-hmm.
At a salary above that, you would get all those health benefits and pay whatever that increment in salary was.
Correct.
So I know how I'm voting.
Sorry, say again?
That means, to me, it seems obvious how to vote. That's not too crass. I'm not going to say what the vote is.
We can't change it again. Yes, Austin.
So this kind of echoes what I said earlier today. I think this presentation, particularly if it shows up in the report in just this way with just this one graphic, which is based not only on the study, but as you've already said, assumptions that you had to make about the salary and incorporating the particular caseload number and so forth.
Right.
It has an anchoring effect, and it's what people both here focus on initially, and I think reading the report probably will too. Now, we're able to have this very long dialogue among many thoughtful people to kind of get our biases and anchors, unmoored, but I worry, as Mitchell did, how it will be interpreted. And one way to get around it is, although we are asked to vote just on this one analysis, you could, of course, show other figures that show other assumptions that you consider reasonable for a sensitivity analysis, so that when people see the report, they don't just see this one figure that shows this,
Sure.
what may be interpreted as a tremendous cost. It makes it more clear that this is just one of many possibilities that are all reasonable.
True. Well, let me ask the ex officio member who's here, given that this is an extrapolation from a single study done out in Seattle, would a CPAC vote on value offer any decision-making guidance that would be helpful to Medicaid programs, or I guess in your opinion, to provider groups and others? I think I know the answer to my own question here. But.
Yes, I think it would offer value.
Okay.
High value, low value, reasonable?
I was actually going there. I was going to say reasonable value.
Sorry, I took your question.
Well, I absolutely take that suggestion as a good one, because I think to try to, if we are going to move ahead and have a vote, if we get the terms clear enough in our minds, if we want to minimize the possibility that Mitchell has raised for us, I think putting in multiple pictures and discussion of that will, in a sense, buttress the idea that this is very much of an estimate, a one shot, and we want to give other pictures as well, so that the vote will be obviously linked to one story, but that we will show that at different salary rates and at different caseloads, you could come up with a different perspective.
Now, we don't know how the vote's going to turn out, but in a minute we will. And if it turns out a particular way, I think the way Bill would like it to, it'll be a very strong presentation, because it'll be the vote will be tied to this picture,
Correct.
But there'll be other pictures that show
that it would even be
you know where I'm
potentially
going. So
higher value.
I'm just saying.
I understand. I understand. The caseload, by the way, was what they used up out in Seattle. That was one thing that we didn't have to assume. Salary, we did. Everything else we tried to take from that study. Yes, Jean?
So I'd like some advice as I think about this. And that advice is, we have an answer in this representation on cost that is solely tied to utilization. And then we have other outcomes to which an economic benefit is not accrued.
Very good point.
So we are not weighing the full economic argument
That's correct.
at the same, so it is our job, in my view, to put together the clinical outcomes and the utilization outcomes into a total package in our minds and vote on that. Is that correct? It's my first meeting. Is that the right thing to do?
Yeah, I mean, again, since we ask you to try to take the perspective of Medicaid directors, you may assume that they care about employment, they care about broader outcomes. So we will try to present those outcomes when they are part of the literature. We will talk to you about the cost that they pay, but we will not try to estimate indirect economic benefits for broader society, because that actually gets to be a very tricky measurement and estimation, much trickier than even what we're trying to do so far.
Oh, I wasn't going
Was
that
that close
far.
enough?
I'm not going that far. I'm just saying that, quality of life indicators are also quality of health indicators.
Oh,
That
very
indicates
much
that
so.
that kid is healthier. So that's not just an economic
Oh,
argument.
no, not at
That's
all.
a health
So
argument.
I think then you're right. You're trying to capture all of the good clinical benefits that come out of this program as they've been described, and the costs that they would accrue to the Medicaid system. Ellen? Yeah.
And just to pile on and lobby, we can look at this and think about, because they had suggested that it would be cost-effective after 3 years. We can think about, based on what we heard, whether that's likely to continue. If you take carpet out of somebody's house, it's gone, because you've gone into the home. So we can factor that in as well as context, right?
One may, yes. We're not asking you to vote on 1 year, within 1 year, is it, we're actually saying, again, someone's asking you, should we do this? Is it a good value, high value, reasonable value? We're going to vote now. All right. Everybody think one, no, give them one more sec. They need a deep breath.
All right.
All right, go ahead.
Go for it.
All right. And we had how many abstentions? One. So noted. Correct? We have 2 abstentions? Did somebody intentionally?
Oh, I might have accidentally.
I know you intentionally. Did somebody else? Sounds like we need to vote again.
We should vote again.
All right, sorry, one more vote?
Unless you have to really see the green.
light.
Yeah, press it. Or, ready? Oh.
Oops.
Sorry. All right, ready, go.
Okay.
Okay.
All right. That went by quickly. Did everybody get a chance to see it? Can you turn it back just so people get one more chance to see the vote? If it's still up?
Yeah, I think as long as it comes on, it's okay.
Okay. High value at the top, reasonable, and low. Okay. At some CPAC meetings, we have actually gone person by person and asked them to describe the basis for their vote on value. We're not going to do that today. We've almost done it beforehand, and we just don't have time, although I'm sure there would be some interest in understanding the perspectives of people who said low value, or because that probably didn't receive as much airtime or lobbying time. So, but we might get that offline. But in the meantime, let's move to the last voting question.
Excuse me, Steve.
Yes.
I think maybe, just to be contrary to what you just said, it would be clarifying to Mitchell's point and help explain what this question and its answer was trying to do. If we did at least look at the 2 extremes of high value and low value. Because I'm interested.
Yeah, I understand. Okay, let's try and do that. I'm just trying to be sensitive to the time, and we have our round table to come. And I know this is the last question. Let's try and do that, but I'll maybe just ask for one person who voted high to speak the reasons. In a sense, I think I know who that might be, but let's have one person describe a high value judgment. You guys sit next to each other, and I'd like to offer the opportunity for someone who voted low to explain their rationale for the vote, and then we'll see if we can move on from there if there's very important other perspectives. But I do want to try to make this brief so that we can get to the next question and beyond. Who would like to speak to the high value perspective?
I already did.
You already did. I think we can capture what you said and describe that as a rationale. Does anybody feel like they need to add something importantly different that drove their high value vote instead of what Bill said? Okay. A low value representative?
Well, since I asked the
Josh.
question. I tried to look at this from the point of view of, in your words, Medicaid. And therefore, it had to be high value compared to what? Something else that was of possibly greater value. And since I figured that some other program for some other clinical issue could come along that had a better return on investment of a limited number of dollars, this was relatively low value. Even though I'm not against making kids with asthma feel better.
All right, I understand. And I think I think the report will benefit from expressing that perspective on this kind of vote as well. Okay, let's move to the last vote on value then. This one is turning to the other program that we chose because of its detailed description and because it represented a different really a kind of a different model in which it's not disease-focused, but more kind of population-focused. This is the Johnson, and I can quickly reflect again, because we're going to ask on whether its outcomes and costs represent a high value, a reasonable value, or a low value. And again, I'll just briefly say, its impact on emergency department encounters per person dropped from 5.9 to 1.8 per year.
A mean over 6 months.
A mean over 6 months, thank you. And the non-CHW arm of this study, it actually dropped also. It dropped from 4.5 to 1.0. But there was more drop in the community health worker arm of this randomized study, and it was statistically significant.
Not randomized.
Oh, sorry.
Comparison.
I thought this one was. Oh dear, okay. Well, then you have to pay attention a little bit more. So the CHW arm went from 5.9 to 1.8. The non-CHW went from 4.5 to 1.0. Emergency department encounters per person per 6 months. Inpatient admissions per person dropped from 0.4 to 0.1 in the CHW cohort, and did not change, 0.1 to 0.1 in the non-CHW cohort. Prescriptions per person, non-narcotic, dropped 31.2, sorry, I don't know what that is, 31.2 prescriptions?
Prescriptions.
Per
person.
patient, wow, that's a lot. I'm assuming over 6 months, it dropped 5.1 per patient in the non-CHW cohort. And the last outcome that they reported were prescriptions. Narcotic prescriptions dropped 4.3 per person per 6 months in the CHW arm, and dropped 1.0 prescriptions per person in the non-CHW cohort. All of these were statistically significant. All right, and you have the picture again of the economic outcome on your brief summary. We talked about flipping the bar just to make it more comprehensible. Any further comment on this study as a basis for a vote on value? Okay, let's go ahead and vote.
Ready, go.
Go. Okay. 93% high value, 7% low value. I don't think we've ever had a vote with no reasonable values. That's interesting. All right. I'm guessing that one person obviously voted low value. Should we capture that reflection in the paper?
I had real problems with this study. I think that we were measuring an awful lot of other things besides the community health worker in regards to this analysis. I think the costs that are presented are problematic, as we discussed when we discussed this study, as to what the cost of the program would be compared to what it would be in New England. And so I guess I was more of a protest vote, that I really don't feel that I can say that this is a strong support of community health workers as an entity, as opposed to an intervention program that employed as part of it community health workers.
Okay. For the sake of our time, I'm going to assume that we can reflect the positive aspects, because I think we can reflect that in terms of the high value vote.